Okay, so welcome to today's University of Ottawa Heart Institute weekly research conference and also the Brain Heart Interconnectome Joint Research Seminar Series. So I will start our seminar today with a land acknowledgement. So we acknowledge that we are situated on the traditional and ancestral lands of Algonquin and Anishinaabe, and these lands are unceded and remain in the stewardship of the Algonquin Nation. We will uphold the rights of the Algonquin Nation and commit to advancing reconciliation through our works. So it is my great pleasure to introduce today's speaker, Dr. Vincenzo Lionetti. So Dr. Lionetti is an associate professor of anesthesiologist at the Scuola Superiore Sant'Anna in Pisa, Italy, where he also served as a director and coordinator of several interdisciplinary research and graduate training programs. So in parallel, he's a practicing anesthesiologist at the Fondazione the CNR Toscane in Monasterio, giving him a unique perspective that bridges the fundamental science with the clinical medicine. So Dr. Lionetti has built an internationally recognized research program in translational cardiovascular medicine, integrating the large and small animal model, advancing imaging, bioengineering, molecular biology, and omics technology to develop novel strategy for the cardiovascular protection and repair. So over the past few years, Dr. Lionetti has led several major European collaborative projects, including a new heart program, which aim to restore the vagal cardio connection after heart transplantation, which he will share mainly, and then also as well as extreme heart project exploring extracellular vesicle mediated mitochondrial transplantation for the end-stage heart failure. So that talk he will share at the RGN tomorrow at 11 a.m. So his work has resulted in more than 150 peer-reviewed publications and numerous international awards and leadership role, including president of Italian Society of Cardiovascular Research. So today's presentation, particularly exciting for the Brain Heart Interconnectome seminar series, because it addressed one of the central questions in our field. How does this neural connectivity influence cardiac aging, cardiac health, and disease? So today, Dr. Lionetti will present his seminar titled The Vagus Nerve Regeneration and Premature Aging of the Heart, and then the heart-brain interconnectome. So please join me in giving a warm welcome to Dr. Vincenzo Lionetti.
Thank you, Dr. Kim, for this nice presentation. And I'm really honored to be here in front of you and Hippocrates, that is on right side, the father of medicine in this prestigious Institute of Medicine. Just I don't have disclosure. So regarding the heart-brain interactome, is a very interesting word, just to explain that these two organs try to communicate each other. And actually, we know that there is a bidirectional communication through neuronal, neurohormonal, and mechanical pathways. And it is interesting that at the beginning we thought it was only related to the autonomic connection, like parasympathetic and sympathetic route. And actually, we know that there are also some humoral factors that are released, like hormones, but even extracellular vesicles that can cross the barrier, the brain barrier, and even the narrow immune connection. So the immune system become very much more relevant, actually, even in this relationship. And at the end, even the old renin-angiotensin system that play really important in the stressful environment due to cortisol. I want to focus on this whole route is the autonomic connection that we know this is much more easy even to investigate, and different clinical approach are related to test the parasympathetic and sympathetic route with different assay. As we know, the innervation, the sympathetic innervation in the heart is much more dense than the parasympathetic one, and is broadly diffuse in the heart compared to the parasympathetic, where you have a main innervation in the atrial anatomic structure and less innervation in the ventricular structure. But one of the questions that attracted me a lot was why we have one single organ with two nerves. So is a redundancy issue or is a laterality issue? There is one left or right that prevail. And of course, regarding the laterality, we know that the cardiac vagus nerve display functional laterality rather than strict anatomical segregation. We know for sure that, of course, on the right side, there is always connection between the vagus nerve and the heart. And from the left side, sometimes there is no connection. They lose connection from the left side in some patients. And we know that from the right side, that where is the right vagus nerve predominantly innervate the atria, but the left vagus nerve has a minor innervation of the atria. The left vagus nerve predominantly innervate the atrioventricular node, and the right vagus nerve predominantly innervate the sinusal, the sinoatrial node. Look the word predominant. It does mean that exclude the left or the right, but is a major component of the right side compared to the left one. But it is interesting that both they innervate the ventricle. We don't know the map of this innervation in the ventricle, but we know for sure that the apex is mainly innervated from the parasympathetic nerve. But why the apex and not the basis? If you can consider that the heart is different movement like squeezing, and then you have a torsion, and then you have the movement from the apex to the basis in one beat. Okay, and actually, other scientists try to demonstrate a laterality concept. This paper was published in 2024 and had seen that the vagus nerve at cervical step is totally different compared to the vagus nerve at the cardiac step. And you can consider that the majority of the study were performed of the cervical vagus nerve, even in the animal. But there are very few studies that try to assess the vagus nerve activity and effect on the heart at the level of the heart. And this paper is very important because, as you can see, the mid-cervical vagus nerve is different compared to the superior cardiac branch. And the right is totally different compared to the left. As you can see, the left cardiac superior branch, they have a major amount of sympathetic nerve fibers and a smaller amount of parasympathetic nerve fibers. And the right one has a larger amount of parasympathetic fibers compared to sympathetic one. So it means that these nerves are different. They are vagus, the 10th nerve. They move from the brain to the spleen and the stomach through the diaphragm. They look like the same. They change form, they change structure, they change the composition, the spatial organization of the fibers where they move from the brain to the spleen, but they deliver different fibers. As you can see here, there is a beautiful comparison of the left-right superior cardiac branch. As you can see, in purple are the neurofilament, in red are the filament that release catecholamines because they have a tyrosine hydroxylase enzyme. And on the left side, you have an higher amount of myelinized fibers. It is MB green, and hydroxylase positive. But on the right side, you have a few sympathetic fibers. Look, On the right side, you have much more parasympathetic fiber on the left side. They release acetylcholine, and they have this enzyme, the cholinergic acetyltransferases. So the right vagus nerve is different. And why in my study I was focusing on the right vagus nerve instead of the left vagus nerve? Not only for the characteristic that I just told you, but even because there was this study published on Journal of Physiology of 2001, where if I try to stimulate the left vagus nerve, I have a negative inotropic effect. Not the right vagus nerve, the left. I have a negative inotropic effect independently of the chronotropic effect. Usually when we try to demonstrate this connection, we try to relate the heart rate to the vagus nerve activity, but we can have tropism effect that are unrelated to the heart rate. This is the key question. That's why the ancient anatomists, they call this nerve vagus. Just not because they don't know how is the structure, how is changed the structure. Can you imagine it turn like a DNA? It has the same angle of the DNA, and it come from the brain till to the abdomen and change the structure, then change the position. So that's why I was focusing on the right vagus nerve. So the cardiac vagus nerve regeneration is a clinical relevant therapeutic target. What we know that if we cut a peripheral nerve, it is very difficult to regenerate the nerve because you can regenerate if you crush, okay? But if you cut the nerve, it's very difficult to regenerate because you lose the wire of the interstitial matrix, okay? There was a study published on 2010 where they used this chitosan nanomicrofiber mesh tube, a C tube, just to guide the reconnection of sympathetic, right thoracic sympathetic nerve, no, in dogs at 3 months. So we know that we need 3 months to obtain the onset of or repair of the peripheral nerve. And we know that you need to support the transected nerve with a mesh made by organic compound like this chitosan, okay? But the vagus nerve regeneration is an idea that comes from far away. The first guy that tried to demonstrate was Dr. William Chamberlain Krusnek, and this is one of the most important experiments that he performed in 1776 in dogs, just to try to cut the cervical vagus nerve in dogs, unilateral vagotomy, and he demonstrated that after a few months you have a fibrous reaction, so you have an anatomical reconstruction, but he didn't know if this anatomical reconstruction was related to the functional reintegration. Though then he tried to cut the other side, the left one, in order to demonstrate if there is also the same phenomenon from the left side. The quick question is that he tried to cut both together, but the dog died. Even in my lab, we tried to cut both the vagus nerve in pigs, and the pig died. So we reproduced the same model of Dr. Krishnak, that was the first medical doctor that tried to assess this question, vagus regeneration. So as you can see that the regenerative therapy is not new, is an old question that can change technology, change the results, change the effort, the clinical effort. Actually, they try different way to regenerate nerve, like suture in this way, but they are not so effective because you have not a direction of the fibers. They try to use a mesh tube, but they use so distant, the stumps, and we know now that we need an interval of 1 millimeter, okay, using a wire to promote the regeneration of fibers. Then some other approach that sometimes works, sometimes fail. But these notes come from a web book notes of 1927. So can you imagine how old is the question? Actually, in clinical unit, we have this problem, is a unilateral vagotomy, that is a rare side effect of lung transplantation, is a rare side effect for other kind of surgical procedure like esophagectomy, laparoscopic approach, is a rare effect, okay? But when we perform the orthotopic heart transplantation, we know for sure that the heart is denervated. It's denervated due to sympathetic denervation, is denervated due to parasympathetic denervation, and we know for sure that this approach is a much more safe compared to the previous one that we use it in cardiac transplantation. We know now that maybe there is a parasympathetic renervation that is very effective after 3 years from the transplantation, but it remains a controversial issue. Parasympathetic renervation could be a reconnection to the brain. We don't know. Why we don't know? Because we don't have available tracer for imaging, try to demonstrate a reconnection to the brain, because the direct stimulation of cardiac vagal branch in the early months post-heart transplantation does not produce a response. And because actually there is much more focus on the intrinsic cardiac nervous system, this neuron, 40,000 neurons that are in the heart, that maybe they provide sprout fibers even without a reconnection to the brain, but could be the same in a human being. This is the graft function survival of patients that undergo to heart transplantation. As you can see, in different age, if you go ahead, the graft function is worse. Even the survival is worse. This difference in the last time is related to the change of the technique, because now we have the orthotopic heart transplantation. But the graft, you lose graft function when you go ahead after the transplantation. And this issue is much more relevant now because the recipient age become older, and even the heart that they give for heart transplantation come from aged donor. So now this issue, it could be very relevant. But the clinical question is, I am an anesthesiologist and ACU doctor. The clinical question is it enough if you reconnect, functionally reconnect the transplanted heart to the brain to improve the survival of the graft and improve the survival of the patients and even the quality of life, and reduce even the amount of rejection after a transplantation? It is enough to reconnect the right vagus nerve, the king, as I know, as the main player between the two vagus nerve that nature gave us. So the question was, artery vagus nerve connection, a therapeutic failure, like the Italian team to the World Cup? Yeah, was very difficult for me to show this slide, but is life. And we perform an interesting studies. I will show you this. Anna Dushpanova, she's a cardiologist. I work in my lab. She's a Kazakh cardiologist, and he is a physician scientist. And this guy on the bottom, Eugenio Redolfi Riva, is a CAM guy. I work in a multidisciplinary team: CAM, engineer, bioengineer, physician, cardiologist, vet med, molecular biology, biotechnology, is a jazz group. So we have a contamination, is an interdisciplinary group, okay? And this guy developed this conduit, is a nerve guidance conduit that we patent, made with these two different materials, chitosan and polycaprolactone, cuff-like. And we want to use the same approach that was efficient in a sympathetic nerve in dogs, okay? Try to reconnect the right vagus nerve to the brain. At the beginning, we want to try to reproduce the cardiac denervation in pigs. So we cut the right and the left, the pig died. The first pig died, the second pig died, the third pig died. Then the vet might say, okay, or you change the protocol or it's over. Okay, so I talked with this guy, Eugenio Redorferiva, this, but our goal is try to demonstrate the vagus nerve regeneration. We don't need to demonstrate right now the physiology. Okay, just cut one nerve and we demonstrate if the nerve conduit can regenerate the vagus nerve. Just that's it. So we need to cut all the nerve just to prove. So we used mini pigs, Göttingen mini pigs, because the physiology is much more close to human. And we performed a follow-up study. At the beginning, we studied the mini pig using MRI, cardiac MRI, echocardiography. We draw sample. We try to monitorize EKG, heart rate variability. Okay. After that, we perform open chest surgery just to isolate the vagus nerve and go close to the heart, right where is the branch, cardiac right branch, not the cervical one of the majority of the study, just the branch. Okay, we isolate this very carefully because the tissue of the swine are very soft, very tiny. You should be very careful. And we isolated this and we cut. We close the chest and we follow the animal for 4 months, just performing cardiac MRI, just performing EKG, blood sample for 4 months. And this cardiology was amazing, Anna Deshpanova, was following the pig like patients every day, 2 times per day, just checking the quality of life. In another group, we try to use the Eugenio uh, uh, nerve guidance conduit. I performed the experiments with a cardiac surgeon, and we put this conduit around the stem at 1 millimeter. Okay, we put this conduit and we suture, we close the chest, and then we perform the same following. Our goal was try to demonstrate the regeneration of the nerve. No more. Okay. I show you the swine cardiac right vagus nerve. This is the right. Unfortunately, I have not the pointer. You don't have. I cannot show you. The, Thank you so much. Thank you so much. Look, this is the branch. This is the vena cava superior. This is the right atrium, and this is the ventricle. We isolated this because the cardiac surgeon, human cardiac surgeon, there is no branch. What? There is a branch. You just go to keep the branch behind the cava superior. Okay, and we selected, we cut, and we put. Look at this, the conduit. Thank you, Mr. Chen. Fei. Mr. Fei.
So on top, this is the later, so this one.
And this is to go.
The advanced and the back.
Okay. So take a look. This is the conduit. This is the heart. So we are very close to very difficult space. Is a difficult space. Believe me. We cannot damage the cava superior because you have a bleeding and the the pig is dying. And then we perform the study. What you can say that this is our MRI unit, our patients. Dr. Acquaro is a cardiology, radiologist, and bioengineering. And the first thing that we did was to check the left ventricular ejection fraction. That is a lovable issue for cardiologists. And what we have seen, there is a light reduction of left ventricular ejection fraction and right ventricular ejection fraction. In the blue is untreated, the red one is treated. There is a light reduction, but within the normal range. So it means that the heart is working pretty well. So the question was, okay, nothing changed, even in patients after transplantation. You go to measure the ejection fraction, you say, okay, it's normal. So you are healthy, fine. But the literature say that the majority of transplanted patients have left ventricular ejection fraction with values above the 55% and continue to be at high risk of early and late death of retransplantation. So left ventricular ejection fraction doesn't mean anything. Okay, so we move on, thanks to MRI, just to evaluate the global left ventricular strain. That is a totally different mess. Strain is a deformation of the fibers, so it changed the point. And what we have observed is much more relevant change out of the normal range. So as you can see here, the treated one stable and the untreated lose the global circumferential strain and even the global radial strain. Look, the treated, and also the global longitudinal strain. These results were the key results to say, oh, something happened. Maybe we put a finger where we should not put a finger. Maybe we discovered something. This data. Why? Because the literature say that each 1% worsening in GLS was independently associated with a 15% increase in risk of events, even the subgroup of recipient with the normal left ventricular ejection fraction. These in patients. Why? Because the reduction in GRS in healthy transplanted subjects during the early post-transplant period is an immediate consequence of the cardiac transplantation. So we reproduce the phenotype of transplanted patients with totally denervated heart, just cutting the right vagus nerve. That's it. So the sympathetic was there, the left was there, just cutting this. Then we analyzed the regional left ventricular strain. This is a bullseye, and we identified the red root of silk. Look, the anterior, mid, apex, all the septal apex. The red one means that are dysfunctional, and the other one, no. So there are some region of the left ventricle that become dysfunctional, and even for circumferential strain, radial strain, and longitudinal, of course, no, because longitudinal is only measured for global left ventricle. And again, the patients. Left ventricular strain in basal, mid, and apex segment remains significantly reduced for up to 1 year after heart transplantation. Here was up to 4 months after cutting only the right vagus nerve. Lack of recovery at 3 months predict death, rejection, and heart failure. Patients, denervated, heart transplantation. Then we went to focus the interventricular dysynchrony. Thanks to Giovanni, we developed this new concept of interventricular diastolic dysynchrony that was not existing before. And we observed that the diastolic dysynchrony was reduced, significantly reduced after reconnection with our prosthesis. Look at this. This is the dysynchrony. This in treated was not dysynchrony. And the early peak of refilling of the ventricle was longer. We go to the clinic and we found something interesting. The interventricular Desynchrony affects transplanted patients during the first year after heart transplantation. It is associated with graft failure. Second evidence, the lengthening of the diastolic period is known to improve ventricular filling, of course, and subendocardial perfusion time and systolic function, regardless heart rate. Because in these peaks, we did not observe changes of the heart rate. The heart rate was quite the same, 63, 62.5 beats per minute. No heart rate change, okay? And what was the main hallmark? I will show you this. This is an MRI. Okay, look at this. Untreated at 4 months, treated 4 months. Look the septal bonds. Look the bundle, the septal bonds. The sept is moving, okay? In untreated, look in treated, is not moving. There is no septal bonds. Usually in clinical, septal bonds is related to pericardiotomy, pericarditis, bundle branch block, ischemic events, low perfusion. In these mini peaks, all the mini peaks are pericardiotomized. There is not pericarditis, myocarditis, bundle branch block, no, nothing. So it's something different related to this disconnection from the right vagus nerve, the king of the vagus nerve. We perform also heart rate variability in a wake, very nice peak, okay? As you can see, there is a restoration, a sympathovagal balance in a frequency domain, time domain, and even look the shape of the Poincaré baseline. 1 month means that does not beginning the reconnection the vagus. No, you need 3 months. And look when at 4 months start to be similar to the baseline. So you have a restoring just one nerve. So thanks to the beautiful paint from Giacomo Balla, the doubt, this reconnection depends on repair or regeneration. And Antonio Paolo Beltrami in Udine tried to evaluate histology. As you can see, he found that on the upper side, there is not, there is a Wallerian degeneration. And disease is untreated. So you have a contralateral, the left one, and look at the treated. Look, these are the wall of the prosthesis. Look, this group of fibers, the survival, and the distal part. Thanks to Valentina Sasso, we went to evaluate the regrowing of cholinergic and cholinergic fibers. This is a contralateral nerve. Look, the untreated is black. Look, the cholinergic acetyltransferase fibers that they are regrowing in the reconnection. We try to assess in each region using the MRI guiding bullseye, okay, the reinnervation of the myocardium. It related to reinnervation? Yes, of course. Even for the chart positive fibers, look at the untreated and the treated in the red area. And even for tyrosine hydroxylase, untreated, treated. Remodeling hallmarks change. Look at the treated one, less perivascular fibrosis, higher amount of arterioles, less interstitial fibrosis, less oxidative stress, and much more relevant, less amount of M1 macrophages, pro-inflammatory macrophages. So the question is, thanks to Tiziano, this allegory of prudence, can cardiac vagal regeneration prevent cardiac fullness? Maybe we touched something that we didn't know because it was so easy under our eyes, and it was not so, was under our eyes for centuries. And what are the hallmark of age-related cardiac disease? Fibrosis, inflammation, macrophages, diastolic dysfunction, mitochondrial dysfunction, and apoptosis. What are the molecular hallmarks that now we know? Shorter telomere, some secreted factors, somatic mutation, epigenetic change, reduced DNA methylation, you have an increase of histone methylation, and some microRNA. So we know these are all the hallmarks. What we observe in our animals, first of all, in the bloodstream, thanks to Dr. Valentina Casiri, she is a biochem woman, we measure these two cytokines in the plasma, interleukin 10 and interleukin 11. These two cytokines are mainly produced from two different populations of cardiac cells, cardiac fibroblasts and macrophages. Okay? And then we went to assess hallmark of aging in the cardiomyocyte. The old one is lipofuscin that you know is related to oxidative stress, and then other like P53 and P21. But was not enough. We tried to evaluate the proteomic profile for each region following the MRI bullseye. And what we observed mainly that in control, you have, look the color, okay? In a control, you have this distribution of the color. In untreated, you have the opposite in the same region. And when you start to treat, you can see that this distinction of the color is not much more strong. Something is changing, something is beginning. And what we observe in treated region, the red one, that there is an improvement on mitochondrial function. So we have an improvement of complex 1 and complex 4. There is an improvement of calcium handling. And so there is also an improvement of cytoskeletal organization of the cardiomyocytes. And is downregulated complement activation and platelet aggregation. We are at the end of the story. We rebuild, I cannot tell you all the data that are published in this paper, but I want to rebuild the story, how it works in premature aging. When you cut the right vagus nerve, the right vagus nerve is the main vagus nerve related to the cholinergic anti-inflammatory pathway. You have a reduction of acetylcholine in the myocardium. That means that you have a reduction of superoxide dismutase 1 level. So you have a pro-inflammatory network that activates the macrophages and move from M2 to M1, so pro-inflammatory. They start to release oxidative stress, but even interleukin 10. Interleukin 10 act, the first cell is involved at the cardiac fibroblast. The first cell is involved at the cardiac fibroblast. Cardiac fibroblasts feel this cytokine and try to release protein, try to release mediators that can improve a pro-aging mechanism. So you have an increasing oxidative stress, you have an increase of a complement protein like C1q, this protein PRTN3 protein increase. You have an impairment of the calcium handling, increased phospholamban. So you have a problem to the circuit. You have a problem to calcium. And after that, you have an impairment of calcium, comes the mitochondrial dysfunction. And the mitochondrial dysfunction promotes the premature aging of cardiomyocytes. When you have a cardiac regeneration, vagus nerve regeneration, you have the opposite for all these targets. And even the phenotype change. So our idea is changing, this is the last slide, changing the cardiac surgery approach for heart transplantation. Nature Cardiovascular Research dedicated us an editorial. The title of the editorial was The vagus nerve is a guardian of cardiac fullness. So the idea is when you have a donor, you just prepare the heart of the donor just to isolate the tail. I always say the heart with the tail. The tail is a small tongue of the right vagus nerve that is behind the vagus superior, the caval superior vein. Okay, you prepare the organ. As you see, the organ that should be used for orthotopic heart transplantation is different prepared. You have the cava vein ready done, is different. Then you prepare your recipient. This is a recipient with failing heart. You just to isolate using this strip, elastic strip. You isolate the vagus nerve, removing from the neck till to the thorax, till to the heart, just to isolate and prepare your right vagus nerve. You don't prepare the left vagus nerve for two reasons. First of all, because not all patients they have connection to the left vagus nerve. Second is because the left vagus nerve is not easy to identify like a branch, because when go through the arc of the arto is try to divide in different small branches is impossible. Okay, but I don't care because we have seen that the king is the right one. So we isolate the right vagus nerve and then we try to connect. So you don't change the technique. You perform vascular anastomies the same. The only thing is a small thing that change. You just to connect with our prosthesis, the stump, the right stump of the recipient with the right stump of the donor, like we did in our pig. Look, the right stump of the recipient, the right stump of the donor's wine. And in this picture, this is the real one. It's very easy, it's very simple, and it's very effective. Just an overview of my model about heart-brain axis dysfunction. We have a different model, I work with different model, even in small animals. I have a model of heart-brain axis dysfunction due to obesity, a double hit, obesity plus psychosocial stress. There is another model where we move this heart-brain dysfunction plus stroke in order to see if a man like me, obese and stressed, could be have a different outcome after stroke. I was inspired by myself, and I use a different approach. Okay, so echocardiography, behavioral test, cognitive test, and even we have a gym for mice in order to evaluate the strengths in mice after a stroke if you have a recovery on muscle skeletal strength. Okay, and then we have a model of Parkinson's disease in order to assess the brain heart axis dysfunction, and is an induced model, and we use this cylinder test assess behavior, but even we are recording the vagus nerve in mice. We built a cuff that was positioned on the in mice just to record what happened to the vagus nerve in Parkinson's disease and the heart-brain dysfunction. Because the concept is that you can have a vagal failure and you can intercept the vagal failure just following the septal bonds of the heart, even in other disease. And the last model is a transgenic model that we made, is a mini pig model that we made with the technique of CRISPR-Cas9, and is a new swine model. There was not this model before, of age-related heart-brain axis dysfunction, that just to delete it, this microRNA 29B. I would like to thank all the collaborators that was working on this mad idea, just using a mad idea to solve an issue with a very easy approach. And thank you for your attention.
Okay, thank you, Dr. Leonetti. It's a beautiful, like very wonderful study. And then linking that, translational, I mean, the clinical conditions to the link to the mechanism. I think it's a really, I have a million questions, but I think probably just put the question to the audience. So the floor is open for the question as well as online. Maybe, yeah.
Hello. Wonderful presentation. I love it. Amazing models. This is curiosity. Since the right nerve is affecting mostly the atriums, you didn't see any atrial fibrillation happening in your models?
No, no, no.
It's
No.
not a potential hypothesis that maybe the generation of the right vagal nerve actually is
We
affected?
monitorize for 4 months, up to 4 months, because it is impossible to go ahead because it's very costly. It is impossible a follow-up study more than 4 months in many pigs because they are surgical pigs operated, so they are very difficult to manage. Okay, and no heart rate variability during anesthesia and even in a week one, we never detect an abnormality of rhythm. Was really surprising, but I have a question. I have the response because there is another part of the study I didn't show you because I don't know if you have time. I can show you. There's only one slide. You want to see?
Yeah, let's do it.
Just to know. Because maybe you feel tired. Look, this was another interesting issue that we published on a journal, is International Journal of Cardiology. What uh, we did something that is very stupid. We cutted the vagus nerve at the level of the heart on the right side and left side, and meanwhile we were recording the neural activity of the contralateral nerve, just to see what it feels while I'm cutting. It's very stupid. Can you imagine? Just simultaneously recording, and you cut on one side and just record on the other side. Okay, even performing other type of recording like blood pressure, hemodynamics, and stuff. Okay, look at this. This MUA is electrical activity of the vagus nerve. Left vagotomy. So, of course, the electrical activity below the cut is reduced, but interestingly, the electrical activity of the contralateral intact nerve, the right vagus nerve, was reducing too. Look at this. I didn't touch the right one. What was reducing? Like was say, I'm really sad that my friends was cutted. And but look what happened if I cut on the right one, the king. If I cut the king, nothing. There is some mechanism that we don't know yet why there is a early compensation that cannot survive for a long time because prevail the catecholaminergic tsunami, no? But in the first time it's try to compensate. That's why we don't have heart rate changes in our model. Maybe it is our opinion that is related here. You have a compensation. So from the left side, we know that there is a laterality to the level of the medulla. From the left side, go up and try to connect on the right one from the upper stump, okay, not from the below. And this is a very interesting study. Look at the heart rate variability in the right cut we found in the earlier time and parasympathetic activity still. So we have something to understand if the vagus nerve maybe is the holy grail. Maybe the heartfulness come from the vagus nerve. Maybe all, if you think all the procedures related to religion, prayers, meditation, breathing, they activate the vagus nerve. And there is the nerve of well-being, right? Is the nerve of wellness. Okay, so maybe the yet fullness is related to the vagus nerve, and maybe Aristotle was right when he was saying that primum oriens, ultimum oriens, no, regarding the art, and Plato was wrong. And maybe everything starts from the art, even the emotion, as my friends from Padua demonstrated, published on PNAS, that the thought feel and the feeling, the emotion are only elaborated at a higher level in the brain, but the sensor remain the art. I don't know if I gave an answer why there is no atrial fibrillation. Yeah. No, this is an acute experiment. It's not a chronic one. And you know how they died? It's amazing. You know how they died? Because if you go to analyze the vascular of the lungs, they have a clot in. Think about COVID outbreak. You had the clot in the vessel. Could be COVID-19 a vagal failure? Because you know that is a neurotropic virus. Super interesting, right? Yeah.
So that sets up my question really well, because I'm wondering if you've studied more, chronic inflammation. Obviously, you showed a slide at the end about psychosocial stress and obesity and other
You mean
conditions.
the model, the other model that I have.
The other models, yeah.
Okay.
But I wonder if you've studied the impact of those. It's not a cut of a nerve, it's not something dramatic, it's not a surgical repair, but it's, maybe injury, maybe dysfunction because of inflammatory environments. And then you mentioned the sort of the wellness, and I mean, they want you to cold plunge, they want you to, meditate and all these things for vagal nerve, restoration. So can you comment on that, on sort of a more chronic dysfunction of the vagal nerve? Like, what's known? And truthfully, I mean, I don't know anything. So what is known about how maybe metabolic disease, chronic metabolic disease, chronic stress? Stress maybe is more obvious, so maybe we won't go stuff, but like metabolic disease, how that might stress the vagal nerve?
Thank you for your question. It is, I will be here another hour to talk, and so the physician will be very happy to stay here and not visit patients, because I'm a physician, I'm a clinician, so I know pretty well how much time you spend to take care about patients. So these experiments, come, they birth from a point, and we found to another point. We didn't know this. So our hypothesis was another one. Okay. Was it discovery, no? And this discovery support an hypothesis that I try to push in the field, that is concept of vagal failure. I mean, you should not stimulate the vagus nerve, but should record the vagus nerve. So you should perform approach to record the vagus nerve activity. And when the vagus nerve, it is a new disease, it is a new concept. Come on, it's a new concept. So if you have a vagal failure, means that you have some issue related to the heart, you have some issue related to the senescence of the heart, and then you are more close to the end that you don't know, even if you are young. So even the sudden death, you don't know if sudden death is related to the vagal failure. There is a group, I was discussing about this with Dr. Kim yesterday, and I'm really interested about this fisherwoman, a Korean fisherwoman in the bio, The name is NU. And because I am a director, I'm master in underwater medicine. And how many of you diving? How many will go underwater just to take a picture and fishing with a shark? Like, fighting with a shark. Okay. So when you go underwater, you have this diving reflex. It's a natural reflex. It means that you have an overactivation of the vagus nerve, so the heart rate reduces, and the heart has the time to fill because the blood coming to the vasoconstriction coming from the periphery to the heart. Okay, so the heart takes time to fill, and like we have seen it, in the reconnection, that you have a filling rate that is higher compared to the untreated. Have you seen it? The desynchrony, the diastolic desynchrony. There was the desynchrony on the left side, and then was this EPFR. Okay, you have time to refill. Okay, this is a dimer reflex, and you can test it if you put your face in a cold water, because it's due to a stimulation of a receptor on the face, okay, even on the eyes. Okay, and if you want to relax, just put the face in fresh water, no, and you have an activation of the vagus nerve. You relax. Did you try? You try? Yes or no? Yes. No. Yes. And this fisherwoman, they lost the diving reflex because they spend all the time diving. They spend much more time of sea lion underwater. It's a cohort of women. And I want to go there with a boat, with my equipment, with an echocardiographer underwater. I want to perform echocardiography of these women while they are underwater, just to assess the cardiac function, and even measuring the heart rate variability with my system, with a cable 30 meter. I won't go there because if I demonstrate that these women, they lost the vagal conduct, exists the vagal failure. And this is supported by the evidence of chronic disease where you don't have the cut, but you have a losing of function. I don't know if it's clear. Okay. If you know someone that gave me money to go there to bio, I will go.
Hello. Hi. Dr. Lionetti, these are truly fascinating work. So thank you so much. My first question is, what's the successful rate of the regeneration of the nerves? Like if we treat 10 pigs, how many of them show this successful reconnection?
Thank you for your question. Okay. The regeneration of fibers was only the 20% in the nerve, so is enough because the amount of fibers that go to the heart are a few. So only a few fibers of the vagus nerve go to innervate the heart. The other go to the spleen, the stomach. And this approach was reproducible. Was not reproducible when we cut both. They was that reproducible, okay? But in this case was reproducible.
Okay.
In all pigs, yes. And when we perform additional experiments, because the reviewer asked us, the reviewer gave us a gift, because the reviewer asked us these experiments. I will show you. This. One reviewer came to us and say, okay, you demonstrated you have not heart rate changes during anesthesia. But anesthesia can affect the conduction of the system. Perform new experiments using awake recording heart rate variability. So we repeated again all the experiments, you know, and we obtained the same results. So, and Lisa Libranti, that is a vet med. I have a group only of women. I have no males, only Eugenio Redolfi Riva and Antonio Beltrami, only women. These are women results. This is a women success, okay? And Lisa Librandi is a very enthusiastic vet med. She performed all this experiment. And we reproduce it. We check the histology. We reproduce the same results.
Okay, thank you so much. Actually, I was not that clear if this is reconnection of the existing fibers or is regeneration, outgrowth of the upstream.
When you have a regeneration, of course you have a regeneration. This was my question when I asked it to a neurophysiology. It was the same question because I was convinced at the beginning was only a reconnection. But the neurophysiology told me, no, forget about it. Because if you have a cut after 3 months, you have Wallerian degeneration. So if you have new fibers, means that you have a regeneration of fibers.
That means outgrowth of the upstream.
They means that they come from the neurons that they come for the fibers. Yeah, we don't know the neurons that they come for fibers.
Okay, thank you. So these are preganglionic
Because you
fibers.
know why we don't know?
Yeah, I don't know.
Because there is laser to monitor by imaging actually, unfortunately.
Okay, thank
If
you.
you develop, tell me, just make a call. I can.
So let me move quickly. There's one question online. I'm going to shorten the question. Okay, so three questions, but okay, which biomarker or physiological measures best demonstrate the vagal regeneration is actually reversing cardiac aging rather than improving short-term heart rate variability or inflammatory signaling? So that was
So they ask a biomarker is the set of bonds.
Okay.
Yes,
Yeah.
this.
I see.
I will show you again, but it's very typical. I have a cardiologist now, they are working in Fondazione Monasterio to stratify patients thanks to this. This is a biomarker.
Okay. Second follow-up question is, given the bidirectional nature of heart-brain axis, do you
Excuse
view...
me?
Yeah.
No, I didn't.
Oh, you can. So given the bidirectional nature of heart-brain axis, do you vagal dysfunction as an initiating cause of premature cardiac aging or consequence of systemic aging?
So is a premature aging related to the organ. It's not a systemic aging.
So maybe I can take a last question. So you also raised a question about, I know we discussed about
No, I want, excuse me, Dr. King. I
Yeah.
want to add why.
Yeah. Okay.
Because we went to detect systemic hallmark of aging.
Mhm.
We did not detect systemic hallmark of aging, even by vesicles, circulating vesicle, only in the tissue, in the myocardial tissue. So it's a premature senescence of the organ. That's why you are young and your heart is old.
Makes sense. So one last question is, I know we discussed briefly too yesterday, but so vagus, parasympathetic system, people talk about there are sex differences, male and female. So I was curious whether your research there covers both sexes, or actually in a pig model, for example. Do you have any insight that maybe the different type of sex differences in the parasympathetic system can influence differently in cardiac aging as well as impact of this
Yeah, this is a relevant question because in the other model I use both male and females, but in many pigs it's really difficult to perform a study in female mini pig because they have time. I mean, mice, they are all the time fertile. You have no problem, okay? But a pig, like human, they have time. So it's different to monitorize. But from an epigenetic view, in my opinion, female are much more tolerant to the aging process because the epigenetic change that you observe is a reduction of DNA methylation. And the women, they are human beings that methylate because the estradiol activates DNA methyltransferase and promote DNA methylation because you need a genetic stability for the future, the spring. No, you cannot have mutation. You have the spring. You should be stable. So, in my opinion, the women could be. That's why the women survive. Okay, and we not.
Okay, so if there's no further question, so I'd like to thank Dr. Lionetti for the great and wonderful talk. Please join me in the thanking back. Okay, so from 1:15 there will be a training session with the Dr. So please join the session freely with him. So thank you all coming.